Today, in this pharmacology lecture, we are looking at drugs used in heart failure. We'll explore their mechanisms of action, therapeutic applications, and clinical relevance in detail. Make sure to check out our companion video, which includes a 10 MCQ quiz designed for revision. By the end of this video, you'll be able to understand the pathophysiology of heart failure and its clinical impact on patient health. You'll learn the primary treatment goals for heart failure management and how they improve patient outcomes. You'll gain an in-depth understanding of the mechanisms of action of key drug classes used in heart failure treatment. You'll also understand the pharmacokinetics of these medications, including absorption, metabolism, and elimination. You'll also be able to identify key side effects, serious adverse reactions, and contraindications of heart failure medications. Finally, you'll learn about the emerging therapies in heart failure management. Now, let's transition to a detailed description of heart failure and its clinical features. Heart failure, HF, is a chronic condition where the heart's ability to pump blood is insufficient to meet the body's metabolic demands. It results from structural or functional impairments in the myocardium, leading to reduced cardiac output and systemic congestion. Clinically, heart failure presents with symptoms such as dyspnea, fatigue, and fluid retention, which significantly impair daily activities. The condition can be classified as systolic or diastolic heart failure based on the left ventricular ejection fraction. Heart failure is a global health challenge, affecting approximately 1 to 2% of adults in developed countries, with higher prevalence in older populations. Its burden extends beyond mortality, causing repeated hospitalizations and reduced quality of life for patients. Treatment goals for heart failure. The primary goals in treating heart failure are to alleviate symptoms and improve patients' functional capacity. Additionally, therapy aims to slow the progression of the disease and reduce hospitalizations. Preventing complications, such as arrhythmias and thromboembolism, is also essential. Optimizing cardiac output to meet metabolic demands is a cornerstone of treatment. Lastly, improving overall survival and enhancing the quality of life remain crucial therapeutic objectives. Pharmacological therapy is pivotal in the management of heart failure, targeting both symptomatic relief and disease progression. Medications address neurohormonal dysregulation, improve hemodynamics, and reverse cardiac remodeling. Combining evidence-based drug classes optimizes patient outcomes and reduces mortality. Let's look at classification of heart failure medication. Drugs used in heart failure treatment are categorized based on their mechanism of action and therapeutic role. These include agents that modulate the renin-angiotensin-aldosterone system, RAS, enhance myocardial contractility, and reduce cardiac workload. Additional classifications focus on clinical applications, such as symptomatic relief, long-term disease modification, or prevention of complications. This categorization facilitates tailored therapy for individual patients based on disease severity and comorbidities. List of subclasses of drugs used for heart failure. RAS inhibitors include angiotensin-converting enzyme, ACE, inhibitors like enalapril and ramipril, and angiotensin receptor blockers, ARBs, like losartan and valsartan. These drugs reduce afterload and slow disease progression. Beta blockers, such as bisoprolol and carvedilol, are integral to reducing mortality and improving left ventricular function. Diuretics, including loop diuretics like furosemide and thiazides like hydrochlorothiazide, manage fluid retention. Other subclasses include aldosterone antagonists like spironolactone, which mitigate cardiac fibrosis, and inotropes such as dobutamine and digoxin, which support cardiac output in acute settings. Let's now look at the mechanisms of action and indications of key drug subclasses used in the treatment of heart failure. ACE inhibitors. Angiotensin-converting enzyme inhibitors, or ACE inhibitors, block the conversion of angiotensin I to angiotensin II, a potent vasoconstrictor, at the cellular level. This leads to vasodilation, reduced afterload, and decreased aldosterone secretion, improving cardiac output and slowing the progression of heart failure. These drugs, for example ramipril, are indicated for patients with heart failure with reduced ejection fraction, HFrEF, and are uniquely effective in reducing mortality and preventing disease progression. Beta blockers. Beta blockers selectively antagonize beta-adrenergic receptors in the heart and vascular system, thereby decreasing sympathetic overstimulation. By reducing heart rate, myocardial oxygen demand, and preventing adverse cardiac remodeling, they improve survival and cardiac function in heart failure patients. Beta blockers, such as carvedilol, are vital in the long-term management of stable heart failure with reduced ejection fraction, HFrEF, significantly reducing hospitalization rates and improving patient outcomes. Diuretics. Diuretics inhibit sodium and water reabsorption at the renal tubules, primarily acting at the loop of Henle or distal convoluted tubule depending on the subclass. This reduces preload and relieves congestion, which helps to alleviate symptoms such as pulmonary edema and peripheral swelling in heart failure. Loop diuretics, like furosemide, are commonly used to provide symptomatic relief in both acute and chronic heart failure, effectively reducing fluid overload, though they do not have a direct effect on improving long-term mortality. Mineralocorticoid receptor antagonists. These drugs block aldosterone's effects by competitively binding to mineralocorticoid receptors in the kidneys and cardiovascular tissue. This action reduces sodium retention, fibrosis, and cardiac remodeling, thereby enhancing myocardial performance and survival. These drugs E.G, spironolactone, are indicated for HFrEF patients with persistent symptoms despite optimal ACE inhibitor and beta blocker therapy, offering an added benefit in reducing morbidity and mortality. Angiotensin receptor neprilysin inhibitors, ARNIs. RNIs are a class of drugs that combine angiotensin receptor blockade with neprilysin inhibition, which increases levels of natriuretic peptides that promote vasodilation and natriuresis. This dual mechanism reduces cardiac workload, enhances diuresis, and improves ventricular function, making it highly effective in heart failure management. ARNIs such as sacubitril/valsartan are specifically indicated for HFrEF patients as a first-line therapy or as a replacement for ACE inhibitors or ARBs to further reduce mortality and hospitalization. Now, let's explore the treatment guidelines for heart failure. The first-line treatment includes ACE inhibitors or ARBs combined with beta blockers for all patients with reduced ejection fraction. For example, enalapril, 5 to 20 mg daily, and bisoprolol, 5 to 10 mg daily, are commonly used. Early initiation improves outcomes significantly. Adding an aldosterone antagonist, such as spironolactone, 25 to 50 mg daily, is recommended in patients with persistent symptoms despite first-line therapy. Loop diuretics like furosemide, 20 to 80 mg daily, are used for fluid overload as adjunct therapy. Second-line options include the use of RNI, angiotensin receptor neprilysin inhibitors such as sacubitril/valsartan, particularly for patients intolerant to ACE inhibitors or ARBs. They provide superior mortality reduction compared to ACE inhibitors. The table presented here is concise, focusing on second-line heart failure therapies and their standard doses. It highlights the use of RNI, aldosterone antagonists, SGLT2 inhibitors, and hydralazine/nitrates. Third-line treatments for heart failure may involve inotropes like dobutamine or milrinone, or ivabradine for heart rate control in refractory cases unresponsive to standard therapies. The table presented here is a concise overview of such third-line treatments for heart failure. Individualizing therapy based on patient-specific factors, including comorbidities and response to prior treatments, is crucial for improving symptom management and clinical outcomes. Pharmacokinetics. Let's review the absorption, distribution, metabolism, and excretion of drugs commonly used in the treatment of heart failure. Absorption. Most heart failure drugs exhibit variable oral bioavailability. Loop diuretics, such as furosemide, have erratic absorption, with oral bioavailability ranging from 10% to 90%. ACE inhibitors, like enalapril, are well absorbed orally, with bioavailability improving when taken on an empty stomach. In contrast, beta blockers, such as metoprolol, undergo significant first-pass metabolism, reducing their systemic availability to approximately 50%. These variations necessitate careful dose titration to achieve therapeutic efficacy. The table presented here is a concise summary of the absorption profiles of heart failure medications. It highlights variable bioavailability metrics and critical pharmacokinetic nuances affecting systemic drug levels. Distribution. These drugs typically have distinct distribution profiles. Digoxin, a cardiac glycoside, has a large volume of distribution, approximately 7 L/kg, allowing extensive tissue penetration, especially in skeletal muscle. Beta blockers, like carvedilol, are highly lipophilic, binding extensively to plasma proteins, with up to 98% protein binding. On the other hand, loop diuretics, such as torsemide, exhibit moderate protein binding, around 90%, and preferentially distribute in the renal tissues to exert their effects. The table presented here is a detailed summary of distribution metrics for heart failure medications. It provides volume of distribution, protein binding, and primary distribution sites for optimal pharmacological understanding. Metabolism. Heart failure drugs are metabolized by various hepatic pathways. Beta blockers, including metoprolol, undergo extensive metabolism via CYP2D6, contributing to interindividual variability in response. Spironolactone, an aldosterone antagonist, is converted into multiple active metabolites, prolonging its pharmacological effects. In contrast, enalapril is a prodrug that is activated to enalaprilat by hepatic esterases, a key step for its efficacy in reducing afterload. Excretion, elimination routes differ across these drug classes. Loop diuretics, like furosemide, are primarily excreted unchanged in the urine, with renal clearance accounting for 60% to 70% of elimination. Digoxin is predominantly excreted by the kidneys, with a half-life extended in patients with renal impairment. In comparison, beta-blockers, such as carvedilol, are eliminated mainly via hepatic metabolism, with minimal renal excretion, making them suitable for patients with renal dysfunction. These pharmacokinetic properties underscore the need for individualized therapy to optimize outcomes in heart failure management. Now, let's examine the safety profile of heart failure medications, focusing on their side effects, important warnings, contraindications, and potential drug interactions. Common side effects of heart drugs. ACE inhibitors like enalapril may cause a persistent dry cough and dizziness, often addressed with dose adjustments. Beta blockers such as carvedilol can lead to fatigue or bradycardia, minimized by starting with a low dose. Diuretics and MRAs, including furosemide and spironolactone, may result in electrolyte imbalances or hyperkalemia, requiring regular blood tests and dietary modifications. Serious adverse effects. Serious adverse effects of heart failure drugs warrant prompt attention. ACE inhibitors and ARNIs can cause angioedema, a potentially life-threatening condition characterized by swelling of the face and airway. Patients experiencing this should discontinue the drug immediately and seek emergency care. Beta blockers, though essential in heart failure management, can precipitate acute decompensation in patients with poorly controlled heart failure or those started on high initial doses. Monitoring cardiac function and symptoms during dose adjustments is critical to prevent this complication. MRAs, particularly spironolactone, may lead to severe hyperkalemia and life-threatening cardiac arrhythmias if not closely monitored. Regular monitoring of renal function and potassium levels can help reduce the risk, especially in patients with underlying kidney disease. Warnings and contraindications. Heart failure medications come with specific warnings and contraindications. ACE inhibitors and ARNIs are contraindicated in patients with a history of angioedema and those taking aliskiren. These drugs should also be avoided in bilateral renal artery stenosis due to the risk of acute kidney injury. In renal impairment, dose adjustments may be necessary to prevent accumulation and toxicity. Beta blockers, such as bisoprolol, are contraindicated in patients with severe bradycardia, advanced heart block, or decompensated heart failure requiring inotropic support. In hepatic impairment, carvedilol requires careful dose titration due to its extensive liver metabolism. Routine liver function monitoring is advisable for safer administration. Safety in pregnancy and lactation. In pregnancy, beta blockers such as labetalol and hydralazine are considered safe for managing heart failure. These drugs do not pose significant teratogenic risks when used within therapeutic limits and under close supervision. Conversely, ACE inhibitors, ARBs, ARNIs, and MRAs are contraindicated in pregnancy. These drugs disrupt the renin-angiotensin-aldosterone system, leading to fetal renal dysfunction, oligohydramnios, and other congenital abnormalities. Their use should be avoided as early as the first trimester. In lactation, beta blockers like propranolol and hydralazine are generally safe, as their excretion into breast milk is minimal and not clinically significant. However, MRAs such as spironolactone and ACE inhibitors should be avoided during breastfeeding. These drugs can accumulate in breast milk and potentially affect infant renal and electrolyte balance, posing risks to neonatal health. Drug interactions. Drugs for heart failure often interact with other medications, necessitating caution. ACE inhibitors and MRAs can significantly increase the risk of hyperkalemia when used with potassium supplements or potassium-sparing diuretics. Alternatives such as reducing potassium intake or using loop diuretics can help mitigate this interaction. Beta blockers may interact with calcium channel blockers like verapamil, leading to additive bradycardia and hypotension. In such cases, switching to dihydropyridine calcium channel blockers, such as amlodipine, may offer a safer option. Clinicians should review all medications comprehensively to avoid adverse outcomes. Lastly, let's look at emerging therapies in heart failure treatment. Vericiguat, a soluble guanylate cyclase stimulator, represents a breakthrough by directly enhancing nitric oxide signaling, improving vascular function, and reducing cardiac workload. Clinical trials have demonstrated its ability to lower the risk of cardiovascular death and heart failure hospitalization, particularly in patients with worsening symptoms despite standard treatments. Another promising agent is omecamtiv mecarbil, a myosin activator that targets the cardiac sarcomere to increase myocardial contractility without raising oxygen demand. This unique mechanism addresses a key limitation of traditional inotropes, providing safer and sustained cardiac support. Together, these therapies offer innovative options that complement conventional approaches, addressing unmet needs in advanced heart failure management. Now that we've explored the topic of drugs used in heart failure, let's take a moment to recap. We've covered the major classes of drugs, including ACE inhibitors, beta blockers, and diuretics, and their role in heart failure management. We discussed how these drugs improve symptoms, reduce hospitalizations, and enhance survival. Additionally, we explored the mechanisms of action and key considerations for initiating therapy in clinical practice. We reviewed the common side effects like hypotension and electrolyte imbalances, along with serious adverse effects such as renal dysfunction and arrhythmias. We addressed safety in special populations, including pregnant patients, and discussed significant drug interactions. Finally, we looked at emerging therapies such as vericiguat and omecamtiv mecarbil. In conclusion, understanding the pharmacology of drugs used in heart failure is critical for optimizing patient outcomes. These medications form the cornerstone of therapy, significantly improving the quality and duration of life for individuals living with this condition. Be sure to check out our next video on antiarrhythmics, where we'll dive into their mechanisms, indications, and clinical significance in managing cardiac arrhythmias. For more in-depth information, refer to Katzung and Trevor's Basic and Clinical Pharmacology, Rang and Dale's Pharmacology, and the latest edition of the British National Formulary, BNF. These trusted resources provide comprehensive insights into pharmacological principles and drug therapy. Thanks for watching. If you found this video helpful, don't forget to give it a thumbs up and share it with others. Subscribe to this channel and hit the notification bell so you never miss an update in the series that we are doing. For more learning resources, check the description below. See you in the next video.